Yesterday we have discussed about the non-drug treatment, and before that we have seen that how to treat the different diseases. For example, hypertension with a beta blocker, calcium channel blocker, vasodilated dilators, AC inhibitors, and we have used many other products. So the continuity of that non-drug treatment, we will see that we can treat patients with the supplements available in the market of calcium, magnesium, potassium, and we can reduce the blood pressure through these supplements. Should not be offered as a method to reduce. Means the main treatment is a drug, but we can also use some supplement in such cases. Or if the supplement is not recommended, then we have to select such a supplement which is helpful to overcome the blood pressure. Obstructive sleep apnea is a strong independent risk factor for stroke and cardiovascular event. Effective management can help reduce the risk of cardiovascular disease. Apnea means sudden stoppage, lack of oxygen due to the obstruction. It happens that in some people, uh, this night apnea happen and the glottis cover the trachea and do not allow air to enter into the lungs, and that causes apnea, means lack of oxygen. It's a temporary phenomenon, but it happens in certain patients. So instrument is available. They have to put on that instrument and take their air through that instrument, and it will help you to open the epiglottis. And if this apnea if continue, it means that there is a cardiovascular event can be happening, means myocardial infarction, cardiac arrest, or something other. Management of other characteristic factors is hyperlipidemia, means excess lipids is present in your blood, especially HDL, triglycerides. And diabetes mellitus, means diabetes with sugar, is also important. Recent trials using the intervention technique for renal denervation to achieve renal nerve ablation and reduce BP in patients with resistant hypertension have not shown any consistent benefit. Therefore, this intervention is not currently recommended for routine use. Drug treatment, we talk about all the patients with severe hypertension can be should be initiated on drug treatment without waiting for the result of ABPM or LBPM, means ambulatory patient who comes to the hospital, or home blood pressure management, or ambulatory blood pressure management. Ambulatory means the patient coming to the hospital. Drug treatment should be initiated in patient with stage 2 hypertension and in patient with stage 1 hypertension with one or more of the following: 10 years risk of cardiovascular disease of 20% or greater and existing cardiovascular disease, renal disease, diabetes, and evidence of the target organs. For patient under age of 40 with stage 1 hypertension but no cardiovascular disease, risk factor, or evidence of the target organ damage, referral to a specialized should be considered for evolution of secondary causes of hypertension. Current treatment of hypertension is based on the NICE guideline, which uses a 4 steps approach: choice of initial treatment depending on the age and ethnicity of the patient. Drugs are prescribed alone or in combination with the aim of controlling blood pressure. Angiotensin converting enzyme inhibitors, type 2 receptor antagonist. ACE inhibitor lower blood pressure through the inhibition of ACE, angiotensin converting enzyme, which is converting angiotensin 1 into angiotensin 2 by combining of the angiotensin with the renin, which is secreted by the kidney, and convert into angiotensin, and this angiotensin 2 is a vasoconstriction and increase the blood pressure. If you control this converting enzyme from angiotensin 1 to angiotensin 2, then angiotensin 2 will not be formed and it will help to reduce the blood pressure, means vasoconstriction will be reduced. ACE inhibitor lower blood through inhibition of angiotensin converting enzyme ACE, leading to a reduction in angiotensin 2 and aldosterone ARBS, the antagonist receptor. And ACE inhibitor or low cost ARBs, angiotensin receptor blockers, ARB means angiotensin receptor blockers, is recommended as first line treatment in patients under 55 years of age. Step 1. ACE inhibitors and ARBs can cause an increase cause in creatinine clearance and hyperkalemia. Increased creatinine clearance and hyperkalemia, these are the major side effects. Serum potassium and creatinine clearance should be monitored at the start of the treatment and then at regular interval, especially after one dose changes and in patients with renal impairment. They are also not recommended, these ACE inhibitors and ARB are not recommended. They are also not recommended in patients of the Black, African, and Caribbean origin due to the risk of angioedema. This is a genetical problem because at the area of Caribbean people and Black Africans, they have certain different picture of their metabolism and bloods and other things. That's why they are not recommended, ARBs and ACs. ARBs are generally better tolerated than ACE inhibitors and can be used as an alternative, especially in patients who cannot tolerate the dry cough caused by the ACE inhibitor. This is another side effect of the ACE inhibitor, that is a dry cough. So remember these 3 points, which is very important. Number 1 is dry cough, right? And other is angioedema, means edema at the heart. So as well as Brady, the The combination of ACE inhibitor and ARB for the treatment of hypertension is no longer recommended due to the incidence of the side effects, particularly renal dysfunction and hyperkalemia. So another important thing is hyperkalemia. This is also a major side effect of your angiotensin and ARBs and angiotensin receptors inhibitors. Calcium channel blockers. CCBS inhibits L-type calcium channels in vascular smooth muscle, the myocardium and cardiac conduction tissues, causing vasodilation and a reduction in contractility and heart rate. The CCBs are first-line antihypertensive agents in patients age 55 or over. Step 1. The dihydropyridine, CCB, amlodipine, felodipine, modified released nifedipine have greater selectivity, have a greater selectivity for vascular smooth muscles. Muscles are are preferred for the treatment of hypertension. The non-selective calcium channel blocker diltiazem and verapamil may be used to in patients with hypertension and concurrent angina or certain arrhythmias, like, for example, atrial fibrillation, due to their additional effect of the myocardium and heart rate. Atrial fibrillation means the heart rate is above 154 beats per minute. However, these agents should not be used in patients with heart failure or in those taking beta blocker. The main side effect of CCBs includes headache, facial flushing, both usually self-limiting, and ankle swelling. So we do not recommend these calcium channel blocker, self channel blocker, calcium channel blockers, and beta blockers. We are not recommending in heart failure patient who has got ankle swelling also, facial flushing or ankle swelling. We can also use the diuretic to control the hypertension, and these diuretics are very helpful to control the blood pressure. Diuresis reduce the salt and water retention. The resulting diuresis reduce the circulating volume and cardiac output, which reduce blood pressure. Thiazide, which are long-acting diuretics, which act on the proximal end of the tubules, kidney tubules, and thiazide-like diuretics are also vasodilators. Thiazide-type diuretics can cause hypokalemia and hyponatremia, means reduction of the potassium and reduction of the sodium, rarely as well as dehydration. Serum electrolyte and renal function should be monitored regularly during treatment with any thiazide diuretics. Thiazide can be used instead of calcium channel blocker in patients with heart failure, step 1 and step 2, or in addition to calcium channel blocker and AC inhibitor or ARB. Avoid thiazide in patient with the diabetic gout. Diabetes or gout. Gout is excess uric acid, urates in the blood circulation and renal impairment. Low dose thiazide like diuretics, for example, indapamide or clothalidone, should be used in preference to the traditional thiazide diuretics such as the bendofluoromethazides and hydrochlorothiazides. Then we talk about for the beta blocker. Beta blockers are no longer recommended as first-line therapy for hypertension. However, they may be considered as initial therapy in younger patients who cannot tolerate AC inhibitors or ARB inhibitors in male child bearing age or in people with sympathetic drives. Beta blockers are also considered at step 4 in patients with resultant hypertension. Target blood pressure for the treatment. Patient age younger than 80 years of age. Clinical blood pressure is more than 140 by 90. Ambulatory patient or home patient during waking hours, more than 135 or 85 mmHg. In patients with comorbidities such as the diabetes patient, hypertension with diabetes, or CKD, achieve of target. Cardiac disease, achievement of target BP is particularly important in patients may require more aggressive BP lowering. This is this is a recommended treatment for the 80 years of age, younger than 80 years of age. Patient age older than 80 years, clinical BP 150 by 90, ambulatory patient management and home blood pressure patient blood pressure management during waking hours less than 145 or 85 mmHg. In the elderly, more aggressive treatment may be associated with poorer outcome, especially due to the drug treatment side effects. Resistance hypertension. Resistance hypertension Resistance hypertension. Hypertension is considered resistance if clinical blood pressure remains persistent, more than 140 or 90 at step 3 of treatment. Addition of a fourth agent can be considered step 4. Low dose spironolactone means potassium sparing diuretics. We call it spironolactone means it do not excrete out the potassium, which is very essential for our body muscles function, especially cardiac function. Low dose of spironolactone in patient with serum potassium less than 4.5 millimoles per liter. Monitor serum electrolytes and renal functions regularly. Higher doses, thiazide like diuretics, patient with hyperkalemia. Consider alpha blocker means alpha receptors are present in the blood vessels, or beta blocker, which is beta receptors situated on the heart in patients who cannot tolerate diuretic therapy and those with the renal impairment. If the patient has two problems, means he cannot tolerate a diuretic because of their side effects or with renal impairment, then we have to consider alpha blockers and beta blockers in patient who is not able to tolerate the diuretic therapy. If blood pressure still remains uncontrolled, refer to a specialist for further advice if not already online. Now we talk a little about acute coronary syndrome. This is acute coronary syndromes are attributable to myocardial ischemia, means it lead to myocardial due to an unstable atheromatous flux. Acute coronary syndrome means coronary syndromes mean the vessels which is supplying to the heart are known as coronary arteries. If they are blocked, what happens? Are attributable to myocardial ischemia means there is a lack of oxygen to the heart muscle due to an unstable Atheromatous plugs caused by plug erosion or rupture associated with thrombus formation, arterial wall inflamed, and significant narrowing of the affected artery. The syndrome covers a spectrum of conditions ranging from unstable angina to transmural myocardial infarction, means this damage of the cardiac muscles. The clinical presentation of acute coronary syndromes depend on the extent of thrombosis, means how big plug is there, distal platelet and thrombus embolism. There is a clots of platelet and it will move into the blood and occlude the vessels flow and result in myocardial necrosis. If the artery is completely occluded, means completely blocked, myocardial damage will occur. The extent and severity depend on the duration and site of the occlusion, where it has blocked and how long it will be blocked. Most patients present with a chest pain Most of the patients present with the chest pain of severity which occur at rest or with minimum exertion. Prompt investigation is crucial to aid diagnosis and guide subsequent treatment. This is all about today and we will continue this lecture next week. Thank you very much.